But with this said, let's switch gear because this is really not the end of the story. If anything, again, to re-summarize, sorafenib, regorafenib, lenvatinib, cabozantinib, ramucirumab, and we're still talking about TKIs. And of course, we really have the whole story of the checkpoint inhibitor immunotherapy. And this is a story that really started with many other diseases, as you know, with melanoma. And proudly this year, and congratulations to Jim Allison and a colleague from Japan for getting the Nobel Prize for the discovery phase of the checkpoint inhibitors. And look where we are now, very heavily involved with checkpoint with regard to HCC. Enough that there's one in conditional approval. So let's talk, Peter. Nivolumab, what's this? What does it do? And why did it get conditional approval by the FDA in the US?
So the concept is striking and a continuation of what started in 2011 in melanoma. The checkpoint inhibitors basically are a brake which in the end stops the immune system of overreaction. And if you loosen that brake, anti-tumor action is reinstalled. That's the simple mechanism. So that is apparently
I like what you
working.
said. This is, very important. I like that because to reiterate this, because there's a lot of complexity to the thing. But really, it's like, we'll call it German car. If anything, it's a brake and pedal of gas. And if anything, really, this is removing the brake, your foot from the brake pedal. I like that. Go ahead.
Okay. So if we have that sort of anti-tumor efficacy, it is probably more likely happening in an inflammatory tumor. And hepatocellular carcinoma is typically taking place in a setting of inflamed liver of hepatitis. So that all fits. And then we have seen impressive results in given patients. The problem what we have is that this conditional approval is based on the Checkmate 040 trial, which was a phase 2 trial uncontrolled. So unusual because we have the potential of inclusion bias, and we have seen many phase 2 trials which did not mature in similar results in phase 3. But what we saw, and that was impressive, were waterfall plots where there was a lot happening in individual patients, and duration of response. That is probably what impressed FDA and was neglecting the fact that this was non-randomized in the phase 2 trial. We are waiting, and that is very, very important, the trial 459, where head-to-head sorafenib and nivolumab are compared.
Fair enough. And if anything, what the best understanding we have is that the response rate, which is the range of about 20%, 15 to 20%, it's not necessarily what really probably the best guess is that's not really what the FDA was most excited about. It's rather the prolonged response, like, patients staying on therapy for a long period of time. That's really probably what was the push for per se for that. So Riyadh, now Peter is mentioning Checkmate 459. There's a lot of lull about that study. I understand that nothing is reported yet. And if you recall, it's sorafenib versus nivolumab. Tell us a little bit more about your perspective on where does it stand?
So again, my perspective from an interventional radiology standpoint is, we've heard about these immuno-oncologies for a long time. There is tremendous promise. As Peter mentioned, there is a modest response rate, but there is a subgroup that have a very long duration of response, and that's what I think the agency was mesmerized by. I've been there several times, and they've quoted that, and that's what they want to see in other clinical trials. We're obviously all waiting for the results of the head-to-head analysis. Are these results real? Is this therapy, this taking the foot off the brake, is this therapy really as good as it is purported to be? So it's going to be the first one that compares in first-line setting head-to-head. We're waiting. I'm here. I was hoping to hear news by the time I got here. I haven't heard anything, but it's really going to see whether, because it may redefine the landscape. I mean, I think one of the things that we've seen is with these 5 drugs that you just mentioned, Ghassan, we're trying to sort of compartmentalize how we do things, but now if this becomes first line, what bumps to the second and who's competing with what? It's a very active field now in the advanced HCC. We'll see what happens. I can assure you that post-progression treatment is going to be a parameter here. because I suspect some of those patients progressing are going to cross over. And so I'll be interested in see how the statistics are managed for that. So nothing but exciting. I mean, it's exciting to see these sorts of things. One thing I want to mention, again, as a radiologist, was important for these therapies is response. Response is a little bit different now. We see the pseudoprogression. This is a new concept now, and I think Peter described it earlier very elegantly, where in some cases you see the response, it looks maybe a little bit larger from inflammation, from swelling. It looks like progression by all classical criteria, but it turns out you maintain the patient on treatment, the next scan it responds, and you have some long-term survivors. Again, as what Peter was mentioning. So this is another very important field of research. We have to figure out what is a real progression versus a pseudo-progression, because I fear we have a lot of patients that are actually progressing that are being delayed an alternate treatment versus those that really have pseudo-progression. From a radiological standpoint, that I think is going to be an important one.